Hello everyone. So I'll be discussing the respiratory test, and the first topic of discussion is pneumocystic. Okay. So we have a 31-year-old man, HIV positive, dyspnea and dry cough, and he's not taking properly anti-HIV drug. Respiratory rate is 24. Chest auscultation is clear. Point to be noted very carefully. Occasionally little bit of scattered cackles. Oxygen saturation is 96 on room temperature, but falls abruptly. This is the golden line to remember. In a HIV positive patient, and oxygen saturation falls drastically on exertion. This is the classical of pneumocystic carinii. So note down this as the golden line to remember. This is a golden line. Okay. And in a case of, so write down oxygen saturation decreasing drastically on exertion is pneumocystic carinii. We treat pneumocystic by co-trimoxazole. So let's talk more about pneumocystis. In HIV, pneumocystic Jiroveci, previously we will call it to be pneumocystic carinii. Okay. Still, in majority of the MRCP questions, you still get pneumocystic carinii. Of course, the new name is like this. Well, it is now. Let's talk more about pneumocystis. It is a unicellular eukaryotes, simple microbiology, nothing special. But the most important line, it's the most common opportunistic infection in HIV patient. Okay, this is again a very, very important line to remember. There's a key word to remember in this particular slide. And again, one more important is, so whenever we are getting a CD4 cell count below 200, this prophylaxis should be started. This question, this line, this is a universal question. This question comes everywhere throughout the world, whichever exam you write. So friends, the two carry home message in this particular slide: most common opportunistic infection, and you give prophylaxis when the count is below 200. Well, let's learn more about the clinical feature of a case of pneumocystic carinii or Jiroveci, dyspnea. Okay, dry cough is not a purulent cough. Fever and very few chest sign. That means chest sign may be normal also. This again a very, very important point. You are auscultating. Patients has come with a fever, dry cough, dyspnea, but you examine it to total no rhonchi, no crepitation, to almost normal, is a classical feature of this pneumonia. Now, one more important question is that what complication can occur? Pneumothorax is a problem. Again, a commonly asked question. So in this, the keywords are dyspnea, dry cough, fever, normal chest sign, and pneumothorax. So there are 5 keywords that you got to remember in this. Remember, we are talking about pneumonia, but no chest sign is the classical finding. Extrapulmonary manifestations are rare, but what can be there? Hepatosplenomegaly, lymphadenopathy, and choroid lesion. The point to be noted that in this particular case, there can be hepatosplenomegaly and lymph node enlarged, liver enlarged, spleen enlarged, but they are not a very common finding, so not commonly asked. But remember, sometimes lesion may occur in the eyes, so-called choroid lesion can be there. Okay, but since it's a very rare thing, so it's not a very important thing. So the patient of pneumocystis has come to you. Of course, fever, cough, dyspnea, indicating some respiratory problem. Like any pneumonia, the first thing is always chest X-ray. Is always the first investigation of choice. First choice. But it is usually normal. may be normal. You may not get any finding in this. So point to be noted, auscultatory finding is normal, chest X-ray is normal. So it can be very misleading also. Misleading in the sense that if the treating physician is not aware that in this patient HIV is there and pneumocystic carinii infection is common, it can be there, then it can be misleading also with no clinical finding, chest X-ray normal. So otherwise it may show bilateral interstitial pulmonary infiltrate. This word is important. The primary pathology is in the interstitium. That's why there is no chest sign. This is the reason, because the pathology is not in the alveoli. Pathology is in the interstitium between the alveoli, the empty space is interstitium. There is the pathology. Very rarely lobar pneumonia etc. can occur, but they are very, very uncommon. They are not a common finding. But the classical finding after chest X-ray, you go for oxygen saturation and exercise-induced desaturation. If this line is so important, the golden line what I told you, if this finding is there in a HIV case, then you are dealing with pneumocystis. Well, you think that is a case of pneumocystis, although there are no evidence as of now. Okay, so no need to say that in this case you like to go for CD4 cell count. Is mandatory to do that, is going to support that you are dealing with HIV. Okay, that is presumed, the CBC and CD4 cell count. So now finally you want to diagnose a case of pneumocystic. What you do? You go for bronchoalveolar lavage. What about doing only sputum? Only sputum is of no use. Why only doing sputum the way you examine for a routine pneumonia? The reason is usually a dry cough. There's not much of the sputum is there. So that's why sputum positivity is very negligible. So you go for bronchoalveolar lavage, you do bronchoscopy, you take aspiration, and that aspiration that you examine under the microscope and use which stain we use. You use silver stain. Very commonly asked question. Can't afford to forget this. So silver stain. You have to use silver stain and BAL. So friends, the key word to remember here are chest X-ray may be normal, otherwise interstitial infiltrate. BAL, bronchoalveolar lavage, is the investigation of choice, and finally you get by silver stain. So there are 4 keywords to be remembered in this particular slide. First keyword, second, third, and the 4th keywords. Well, after that we have diagnosed. The treatment is co-trimoxazole is the first line treatment. In very severe cases, we can even give intravenous pentamidine can be given, or even aerolized pentamidine can be given. But this is second line treatment. So when this is the answer, this is the best answer. Always remember, even if the 2 are given, pentamidine and co-trimoxazole, go for co-trimoxazole, the first line treatment, because this pentamidine is less effective. So that's why you always go for the best treatment. Now, so first treatment is co-trimoxazole. So this is the key word to be remembered. Pentamidine is the second line treatment. But now steroids. The third keyword is steroid. This when we give when the hypoxia is there. That means when the partial pressure of the oxygen is less than 9.3 kPa or less than 70 millimeter of mercury, that means patient is going toward hypoxia, then only you give steroid, otherwise steroid are not given. Okay, so when you give when you give steroid in a patient of pneumocystic, it reduces the risk of respiratory failure and by 50%. 50% is a huge percentage, and death by 1/3 again. Lot of benefits are there. So friends, to summarize the whole show, treatment of a case of pneumocystic, number 1, co-trimoxazole, keyword. Number 2, pentamidine, which can be given both IV and even by nebulizer also. And third is the steroid, but this we give when the PaO2 is less than 9.3 kPa. Okay, so 3 keywords in this particular. And so the golden line to remember is the pneumocystic is given, is treated with co-trimoxazole, and we give prophylaxis. Write down one more, you give start prophylaxis even he doesn't have pneumocystic carinii in a case of HIV. Prophylaxis, this you start when the CD4 cell count is below 200 per ml. So there are 2 golden lines to be remembered, and in the prophylaxis also we give co-trimoxazole. So friends, the first keyword is treated with co-trimoxazole, and even prophylaxis also co-trimoxazole, but we give when the CD4 count is below 200. Question number 2. Now the things are easy, your basics are clear. You got 28-year man, immunocompressed, dyspnea, dry cough, bilateral interstitial infiltrate, and he is giving co-trimoxazole empirically. But now, okay, sudden worsening of his dyspnea. In the morning, he got up, sudden worsening and left-sided pain chest. So he is a case of immunocompressed. That means he is a case of HIV. Or we presume immunocompressed HIV, dyspnea, dry cough, bilateral interstitial infiltrate. They are pointing toward the pneumocystis, and he has been given co-trimoxazole empirically that most likely he has pneumocystis. And one day he complained of sudden onset of dyspnea. This is due to pneumothorax. Pneumothorax, we learn, is a well-known complication of a case of pneumocystic carinii. So now, of course, it's not a direct question, but let us rule out other possible causes. Empyema, it never gives rise to sudden onset of dyspnea, never. It is always a very slow process. And empyema is not a complication of pneumocystis. Pulmonary embolism, it can lead to sudden onset of pain chest, okay, or sudden onset of dyspnea also. One possibility is there, but in the setting of HIV with lung infiltrate, dry cough, so this is a better option. This is definitely a better option, but yes, possibility of pulmonary embolism has to be kept in the mind. Acute respiratory distress syndrome doesn't lead to pain chest. It leads to dyspnea. It doesn't lead to pain chest. Okay, it doesn't lead to pain chest, and there is a bilateral problem is there, right? So ARDS is ruled out, and pericarditis, it never lead to sudden onset of pain chest. Even ARDS doesn't lead to sudden onset of pain chest. So the one close competition with pulmonary embolism, but again giving in the setting of HIV, this is the better idea. And moreover, there is no predisposing condition for pulmonary embolism, no predisposing condition. Okay, so that's why this is not the answer. So friends, the carry home message, golden line to remember is, golden line, pneumocystic Jiroveci pneumonia, pneumothorax is a common complication. Golden line to remember, right? Question number 3. You are getting HIV positive patient, started on anti-HIV drug, and viral load has gone down, but CD4 cell count is now 184. 184. What should be added? Well, Viral load has gone down, but CD4 cell is below 184 and it is less than 200. And one of the very commonly asked question that in such cases you have to add prophylaxis for pneumocystis carinii, and we give co-trimoxazole, right? Now he says that what else should be added in the prescription? Okay, so he's asking for, of course, prophylaxis. These three drugs, prednisolone, we don't use for prophylaxis. Rifampicin also, we normally don't use for prophylaxis, except we can use for prophylaxis in case of meningitis, meningococcal meningitis. We can use this as a prophylactic drug, but that is altogether different scenario. Nitrofurantoin is used for UTI, but not for the prophylaxis. Acyclovir we can use for some time for herpes, normally for treatment, but again very rarely this can be used as a prophylaxis also. So hence in the setting of HIV, the best answer to this question is co-trimoxazole, because it is CD4 cell count is below 200. Okay, so the golden line to remember is a patient with CD4 cell count below 200. Prophylaxis should be given against pneumocystis carinii, and for that we give co-trimoxazole. Point to be noted, for the treatment as well as prophylaxis, we are using that same line. First line drug is always co-trimoxazole, both for treatment as well as prophylaxis. 34-year HIV positive taking co-trimoxazole, and now the PaO2 is 8.2. What to be added? Now your concepts are very clear. So we learned that if the PaO2 is below 9.3 kPa, then we add steroids. And what we learned, that when we add steroid, it reduces chances of respiratory failure by 50%, and it reduces the chance of death by 33%. So hence we use steroid when the peak, when it is less than 9.3, it is 8.2, you will be using steroid. Meropenem and they have no role in treatment of pneumocystis. Even these have no role in the treatment of pneumocystis. So friends, golden line to remember, steroid is added when the PaO2 is less than 9.3. In our question it is 8.2. Question number 5, again 44-year-old man, HIV positive, shortness of breath, and which is the most characteristic of pneumocystis carinii? Answer is normal chest auscultation. Let's use the rule out technique. It usually occurs when CD4 count is between 200 to 300. It is wrong answer. It occurs when it is below 200. So this is not the answer. Absence of fever, wrong answer. Fever can be there. Productive cough, no, it is a dry cough. That's why dry cough, rather no sputum or very little sputum. That's why when we did the sputum examination, we got nothing. Is all dry cough is there. Oxygen saturation improve after short period of exertion. No, it reduces. In fact, this is the most characteristic finding. Most characteristic finding that the saturation falls, not increases. He's talking about increasing. So what I told you initially also, one of the classical features that chest auscultative finding is normal, but if the hypoxia occurs on or saturation falls on exertion, is a classical finding in a setting of HIV. The normal chest auscultation can be there, even chest X-ray can be normal. Okay. Well, we got another patient of 29-year-old HIV. He has come from South Africa where HIV is very common and anti-retroviral and started taking HIV drug. Chest is unremarkable. Unremarkable means there is no clinical finding. But a chest X-ray shows bilateral interstitial shadowing. Point to be noted. So what's the next investigation? You go for bronchoalveolar lavage. The point which is favoring that the patient is a case of pneumocystic is normal chest X-ray, and you are getting a normal examination of the chest clinically, and you are getting interstitial infiltrate is most likely pneumocystic carinii, for which the best investigation is bronchoalveolar lavage for to diagnose the case of pneumocystic. CT thorax, this will not give you diagnosis of pneumocystis. Biopsy is not done. We do aspiration. Biopsy we do only in some case of cancers, not in case of pneumocystis. Sputum culture, no, it is not the answer. We simply need BAL, and we have to stain with silver stain. Good enough. And blood culture and sputum culture, they are not going to give any result to us. The bronchoalveolar lavage is the best investigation. The golden line to remember that in pneumocystic carinii, the definite diagnosis is by bronchoalveolar lavage with silver staining. Okay. We are getting 39-year-old man, HIV, bilateral pulmonary infiltrate, and you are thinking of pneumocystic carinii, bronchoalveolar lavage done. You will stain by what? You will be stained by silver stain. I think this point I discussed earlier, so no need to discuss. Right, so silver stain in BAL is the classical thing that we do in a case of pneumocystis. Friends, pneumocystic carinii is a very, very favorite topic of the MRCP. So whatever question I discuss, you will be definitely getting one or two questions from what I discuss. Okay, and I've been telling you, whatever I'm teaching, if you read this, especially the golden line what I'm giving to you, you must read a day before your exam, and your most of the question will be based on what important keywords and golden line I'm giving to you. Okay, thank you very much. God bless all of you.